So the biologics in the shoulder, in the rotator cuff, should be based on two things. One is the injectables which you have, and second is the patches and the augmentation which you have. So I thought I will go through some literature and whatever results we have on this kind of scenario. So coming to the biologics, we'll start with the injections. The question is there any role of any kind of injections in the cuff healing? So when you look at literature, literature is always biased. You can have literature that way or this way. There's no proper literature which says that it supports PRP in the usage. Then coming to PRP, PRP is just not just PRP. We have Lucozade rich, Lucozade poor, Lucozade very poor, different types of PRPs which are available. So when you look at what is the ideal PRP which might work, so the principle should be to induce inflammation. Only then you have more healing. So then you're looking at the Lucozade rich PRP. So when you look at the different companies, so we did a study on different companies looking at what each has. So it looks like a double spin which we normally get from Arthroscopy normally has Lucozade rich PRP, and that is what we normally use. So now you can see this, this is on a systematic review on these are the different types of PRP and the different uses. So we prefer the Lucozade rich. Then as I was saying earlier, there's no proper data which actually says for or against. But definitely there are definitely some, if you look at this is a 2025 paper, systematic review meta-analysis. So musculoskeletal surgery, pretty good results. So they are saying that re-tear rates are lesser if you use, along with the rotator cuff repair, if you are using PRP, it is supposed to be better it seems. Then at the same time when you look at a 3-arm control, so you find that there is no particular difference in the different rates overall. So that's it coming to, so we decided to do our own study on the PRP and how it works. So when there is, so when we look at literature, we find that we can divide it as into two categories. First is degenerative and traumatic. So degeneration basically means there is some other pathology behind it. It is degenerated. So we didn't want to select those patients. So we took traumatic tears. In traumatic tears, further we classify into high grade and low grade depending upon the size of the tear. So high grade tear, higher chance of progression, so we operated. In low grade tears, less than 50% thickness, we started to give the PRP injection. So we had two arms here. One is the PRP and the physiotherapy arm. The other is only the patient who opted for the physiotherapy. So you can see that there is quite a bit of difference. So in the outcomes. So we see that. So you can see the green is basically the PRP. So this is So this is the PRP pre-injection and post-injection. This is the physiotherapy before and after. So then you look at it, you can actually find a difference. There's quite a bit of difference in the different scores, constant scores, ACS scores, quick dash scores, and the VAS scores also. There's a reverse of it because these scores are the reverse. These are positive scores. These are negative scores. So quite a bit of difference we did have. So in these traumatic patients, when you look at the return to sport, again it is quite different. In the physiotherapy arm, it was at 20%. And here it is 50% return to sport. So in our patients, we followed this, and we don't have any evidence on the remaining. We don't know about degenerative tests. We don't know about high-grade tests. But definitely, it looks like in low-grade traumatic rotator cuff tears, we did have good results. Now coming to BMAC. BMAC again, all of us know. Okay, we definitely use the BMAC for cartilage repairs and all that. So there is some evidence on the BMAC saying that it could affect, it could have a positive outcome on the rotator cuff healing according to some studies like this. We don't have any experience on that. Coming to MSCs, so mesenchymal stem cells. So we worked on the MSCs quite a bit. We tried to find out some data on it. When you look at MSCs, how it works in rat models, definitely MSC, that is stem cells, when injected, different types of stem cells. You can have adipose-derived stem cells. You have allogenic stem cells where you it becomes, you can isolate it and it is not patient specific. So these stem cells definitely seem to have a positive effect. If you look at it, see the MSCs remained in the muscle tissue for 7 days. These are mouse models. It had a positive effect and increased the muscle growth and muscle protein growth. So when we look at certain studies, there is only very few studies with the MSCs. So these studies, one study showed positive outcome, the other study said not much of outcomes. I use this kind of things only in kind of re-tear scenarios. So here again the patient had a re-tear. I took the biceps and you can actually compress it. There's a compression device you can put it on top. So this is patient autograft. That's the biceps which is coming in. So biceps, and coming to biceps SCR. So biceps SCR is where you use the biceps from the attachment of the bicep, the root is intact, and you cut a long and little more down. So we had followed up almost, we had 100 patients. We reviewed 100 patients and we had excellent results of biceps SCR. This is our own study. You can see the number of patients and follow-up. Biceps SCR is, and these are the outcomes. You can see the outcomes, pre-op and post-op outcomes. Excellent scores. So this is a biceps SCR. You can see the rotator cuff like that. The biceps being isolated. And bicep being integrated into the repair. I don't have much of time, so I'm not explaining it. So our study, when you're looking at our outcomes, you can see our study as well as the McLaughlin et al. Study. So we have comparable results, pretty good. Next is the facial data SCR, we use the IT band. So this is the facial data SCR. What is the facial data SCR? It is invented by Mahabhihata. So basically the anterior posterior force couple should be intact. So what we do is, we modified this technique. We added the biceps also along with the facial data, like this. The yellow color thing which you see here is the biceps. On top of that, the facial data is there. So you must see this. You can see the thing on the right. Okay, you can see here is the biceps, long head of biceps. You are basically stitching it down. Then you're finding out what is the remaining cuff defect, and you take the facial data. You double it or triple it, make it to 8 mm thickness, and with the sutures in this particular pattern, you have to guide it like this into the into the shoulder. And then you have to do, most important thing, to have a side-to-side suture. So it's very important because only when the force couples act. So this is the facial data SCR. These are the outcomes of this particular technique. Facial data plus biceps, the techniques, outcomes are pretty good. So these are the different options which we have. And so we have options. Okay, so PRP, there is no guideline. All these injectables don't have any guidelines now. But I think with the future, okay, we'll have more of things. Thank you so much.